نشوف. طيب Perioperative Management. This is the outline للمحاضرة اليوم اللي هي راح نحكي عن ال Pre-op Management. أول شيء Pre-op Evaluation و Risk Assessment. For the risk assessment, we have different kind of risk assessment. One is, and the most important is a cardiac risk assessment, and then pulmonary. We have also hematology and endocrine, and then the second, like also after the procedure, we have the post-operative management. اليوم راح أحاول أحكي at least for the pre-op evaluation or cardiac risk assessment. And a subsequent lecture إن شاء الله راح أحكي عن pulmonary and hematology with and endocrine complications. To start the lecture, هلا hopefully إنه يكون كل واحد معكم واحد إذا في حد إذا كلكم معكم ورقة وقلم أو أي شيء يعني just to take notes. راح نعمل فيها four questions. ما راح أحكي الأجوبة يعني راح go over the questions. But you write down the answer that you think it's better. بعدين at the end of the lecture, we'll go back and answer them. وهي الطريقة بنشوف إذا الواحد ممكن يعني we got the main points in the lecture. So this is the first one. 75-year-old man with medical history of stage 3 CKD, hypertension, hyperlipidemia, evaluated for colonic resection. He's asymptomatic. No history of abnormal bleeding and tolerated left knee arthroplasty 3 years ago without complications. Family history is negative for bleeding. Medications, lisinopril, hydrochlorothiazide, simvastatin. His exam is basically benign. His BMI is 29. Which of the following pre-op tests are indicated? A, ALT, AST. You don't have to give me the answer. Just write it down. اكتب الانسر اذا عندك ورقه او على اي نوت وبعدين at the end of the lecture we'll compare. B, PTT and PT and PTT. C, serum creatinine and electrolytes. D, nothing to be done, no test. And E, B and C. All right, it's gonna be quick, just like brainstorming, so it doesn't have to. We're not gonna spend a lot of time. Just all right. So I'm gonna go for the next one. 55-year-old man fractured his pelvis. He's gonna go into for pelvic surgery tomorrow in the morning. He has a history of hyperlipidemia, hypertension, coronary artery disease, and ST elevation 2 years ago with drug-eluting stent. He takes atorvastatin, metoprolol, amlodipine, and aspirin. Main thing on his exam, his blood pressure is 170/90. His heart rate is 102. Cardiac examination is unremarkable except of tachycardia. How do you manage his medications? Continue everything, stop atorvastatin, continue everything and withhold aspirin, continue everything and withhold amlodipine, or continue everything. Question number 3. 70-year-old man is seen for pre-operative evaluation for laminectomy with spinal stenosis. He has a history of coronary artery disease, non-ST elevation 5 years ago. He swam 30 minutes, no chest pain. His medications are aspirin, simvastatin, metoprolol, and lisinopril. His physical exam is benign. He had an electrocardiogram performed 2 years ago. It showed that he had left anterior fascicular block, PACs, and sinus rhythm. Which of the following is indicated before his surgery? A stress test with dopamine, electrocardiography or ECG, exercise stress testing, no further testing. And the last question, 60-year-old woman is seen for pre-operative medical evaluation for elective total left knee arthroplasty. She experiences occasional dizziness after walking for 30 minutes, no other problems. Her exams is remarkable for 3/6 systolic murmur. The lungs are clear, no lower extremity edema. She had an echocardiogram about 2 years ago, and it demonstrated moderate aortic stenosis. Which of the following tests are indicated preoperatively? Again, same question, same answers. Dobutamines, electrocardiography, exercise stress testing, no further testing, or echocardiogram. Maybe you can add echocardiogram. Actually, I made them. Actually, yeah, there should be another option. Is echocardiogram. Let's consider it as E. All right. Yeah, just like quick brainstorming, then we'll go back. هلا بالنسبه للبري اوبريتيف ميديكال كونسلتس بيجوز البراكتس بين البلدان والميديكال سوسايتيز از ديفرنت. في هون in the US يعني بيطلبوا الكونسلتس على اي حدا، حتى على الارجنت اوبريشنز. ما اتذكر مره طلبوني على واحد اصبعه انقطع انه to evaluate for medical clearance, which doesn't make sense. ففكره الميديكال كليرنس should be يعني adjusted. We don't do just medical clearance, we do pre-op medical assessment. We take the whole picture and then we give recommendation. فكثير من الجراحين او السيرجيكال تيم بيحكوا مع الميديسن تيم بيطلبوا can you come and clear the patient to the OR. فهاي medical clearance word should not be used anymore, and now there's a lot of trend that not to use it even like when we give recommendation. بالنسبه لشغله الثانيه الموجوده كمان اللي هي بتختلف في البراكتس بين بلد لبلد او society لسوسايتي، اللي هي هون at least in the US there's a lot of influence on the malpractice. يعني السيرجن بيطلب الميديكال consult just because if anything goes wrong the medicine team will be blamed for. فلو صار عنده MI بعد السيرجري بس اوكي الميديكال تيم هو يعني عشان ما ينحسبوا عليه انه اذا surgical complication. ما بعرف بالنسبه للبراكتس بالنسبه لبلادنا يعني بشكل عام السيرجنز عندنا خصوصا بالببليك هوسبيتالز يعني they take the risk. بالبرايفت it depends يعني انه they want to do the surgery whatever it costs للاسف. فهون it comes اللي هي الميديكال consult انه to optimize the patient but at the same time not to delay the surgery, and there's like this balance between the two. We will try our best to co-manage and optimize the medical conditions for the patient. At the same time, we don't want to delay it to the point that it will be adversely affect the patient if we delay it further. فهون بيجي السؤال، طيب هلا it's a widely practiced some commonly practiced thing انه surgeon to ask for a consult before the surgery, even sometimes with low risk patients or sometimes for urgent cases. Is it beneficial? That's the question, and this is like as any other medical problem, that a research question. Is medical consult before surgery helpful? Actually, surprisingly, the evidence is conflicting. It's not clear cut that is beneficial, and even in the studies that showed some benefit, the benefit was marginal. It's not like people who got medical consults before the surgery, they kind of like had tremendous effect afterward. But 2 points to make here. First of all, most of the evidence that we based on is retrospective analysis, and although retrospective analysis sometimes is a good evidence, especially if it's like a large pool of data, but it's still retrospective, and the only way to kind of like validate any evidence is to do a randomized controlled trial. There was like a small randomized controlled trial that happened like a long time ago. But still, it has a lot of confounding and the evidence is not very strong. The second point to make here is that they found that the outcome is different based on the type of surgery. For example, like, did better compared to neurological surgical patients when they compared between the perioperative outcomes. So to make the best out of the consult when you get any consult is to practice evidence-based medicine, and that's what we're going to do here. At the same time, try to have a closed loop conversation with the surgical team and how to implement your recommendation. A lot of time اللي بيصير انه you go and see the patient and ask the patient, like ask the surgical team to do something or not to do something, and sometimes they don't listen. It's kind of like, this is different mentality between medicine and surgery. And medicine sometimes will be more on the cautious side. Surgeon, they don't just want to do the surgery. So a lot of time there will be discrepancy, like أو خلاف على what to do best for the patient. Just to give you an example, عندنا في بالمستشفى اللي بشتغل فيه they implemented a medical team consult for all hip fracture patients. أي مريض hip fracture بيجي أول ما يدخل الهوسبيتال medicine team should be involved. We evaluate the patient pre-operatively and we co-manage the patient after the surgery. And like when I say co-manage, like we even put the orders and like حتى بدون ما نحكي يعني للسيرجن شو مرات شو ممكن نسوي يعني. They analyzed the data and actually they showed like really significant improvement in the 30 days mortality, length of stay, blood transfusion. So overall, medical consult is beneficial. It depends on where it's done and how it's done. So other general rules, the first thing that, like when you get a call from the surgeon, either as an inpatient or an outpatient, the first few things that you should know is determine the urgency of the consult. Is the surgery is happening tomorrow or in 30 days or in a year? So, and this will give you time frame to optimize your patient. At the same time, you want to know exactly why they're calling you. في مرات okay, is it medical clearance or is it co-management بكون مريض مثلا عنده a lot of comorbidities, diabetes, coronary artery disease. ف يعني مرات تكون صعب على surgical team to manage all this, so and they just want to have a specific question: should we hold, for example, anticoagulation or not? And why this is important, because sometimes the medicine team actually they get blamed on delaying surgery for an unnecessary reason and do a lot of workup that is not necessary. For example, patient is on, he's had AFib and CHF, he's on warfarin, بيحكوا معانا, can we hold, we can't hold. بروح medical consult, بروح بيعمل echocardiogram أو unnecessary test that will delay the surgery further. Another important point is that you don't give recommendations for anesthesia. This should be done by anesthesia team. Like, I mean, local versus general anesthesia. And by the way, some evidence doesn't suggest like any difference between in the outcome. It is very important to be thorough, but to be focused. إحنا as a medicine, the mentality تاعتنا to be very, detailed in history, take, like recommendations very detailed, which is like different than surgery. But and the consult is different. When they call you for a specific reason, as I said, like manage anticoagulation, you just manage this. If you feel that there's something else that you want to manage, you just give recommendation and just move on. Again, as I said, optimize but don't delay. So the three main points, like whenever you do a medical consult, is the first one is risk assessment, to assess the degree of severity for all the medical comorbidities the patient have and estimate the surgical risk. After that, based on that, you optimize the patient condition and decide if there's any further test or intervention should be done before the surgery. and the next step will be co-manage all based on what you have done before, is to co-manage the patient with a surgical team, either pre-op or post-operatively at the same time. And for the first step, which is risk assessment, there are two things that you look for: the patient risk, patient own risk, and the surgical risk. For the surgical risk, probably we don't really have much to do with it, right? It's like, it depends. There are two things that you look for. First is type of surgery and like what kind of risk that that surgery carry. We don't have an option for this, and this all for the surgical risk, it's either low, intermediate, or high risk. I'm not going to go over all of them, but probably it's kind of like important to communicate clearly with the surgeon about, is the surgery high risk, for example, bleeding, duration of the surgery, and because this all of this will like make you base your decision based on that. and for the urgency of the surgery, like there's urgent, emergent, and elective. This is also important to ask the surgeon when you're going to do the surgery, because this will also give you time to optimize your patient. For the patient risk, this is when we come here. It depends, like there are different types of risk. General risk for like general population and healthy population, cardiovascular, pulmonary, bleeding, and endocrine. As I said earlier, we're going to go mainly over the two, above the first two, and then later on we'll do another lecture for the rest of the risks. So when you encounter our consults, it's like encountering any patient. You start with a history and exam. You follow that by blood tests and imaging if indicated, and you feel that is further testing is needed, you do it. For the history and exam, as I said earlier, it should be focused, but at the same time thorough enough but focused. Again, here we're not dealing with like infectious disease cases, like where you have to kind of like take all these details about travel history, exposure history. You do kind of like basic assessment. What is different on a medical consult compared to kind of like probably some like other patients that we encounter is that you have specific things that you have to ask for. For example, the exercise capacity. There's like a specific way of asking it. Obstructive sleep apnea is often being ignored, or we forget to ask about it. And also for the obstructive sleep apnea, there's like specific questions and a questionnaire. Medications sometimes get like ignored, or like kind of not properly we ask for it. And especially if the patient is being admitted by the surgical team, sometimes they don't take like a detailed medication history. And you, like after the surgery, you realize that the patient was on, for example, clonidine, and that's why his blood pressure is high. It is also important to ask about smoking, because smoking increases the risk of perioperative morbidity, at least. And family history sometimes is beneficial for like bleeding, diseases, in a very, very rare cases, like, probably this will be asked by the anesthesia, is malignant hyperthermia runs in some families. For exam, it's the same thing, focused but thorough exam that will take you to the point. It's important to know the BMI of the patient, because obesity is a risk factor for perioperative complications. Now, when it comes to functional and exercise capacity, there are two main things that kind of like commonly being asked for. The first one is metabolic equivalent. activities I'm putting here الموجودين على الشمال this is not the only thing that you ask for, but this is just kind of like almost a sample. Metabolic equivalent is basically it's a scale that how much energy you the body will need based like on the activity that we're doing. It ranges from like a very very simple activity to like a very strenuous activity and sports, and based on that you score the patient. Like the simple one would like we'll get 1, intermediate kind of like going upstairs like درج يمشي شوي كمان خطوة. This is 4. Slightly a little bit heavier, 4 to 10. It's very scoring for each point. The problem that you're not gonna ask 12 questions للمريض يعني بالعيادة أو حتى بالhospital. I don't feel that is like it is very practical. A score of 38 was associated with a higher risk of or was less associated with risk of complications. So when it comes to blood workup, so this is for the history. Now you go for the next step, which is blood workup. And here's like when هاي هي النقطة اللي بجوز كتير في من الانترنست حتى السيرجنز. There's like a lot of debate and mistakes that happen. كثير مرات عشان البراكتس for the sake of خلص الواحد يعني يعمل اللي عليه بطلب كل التست هدول either indicated or not indicated. هلا لو تفكر فيها لو واحد يفكر فيها بصير يحكي اوكي ماشي الحال يعني شو المشكله لو عملنا هاي التست يعني بجوز it's not very expensive. But if we want to take it on a larger scale لو شوف كم مريض بيعمل سيرجري خلال السنه وكم مريض بنعمل له فحوصات مش مطلوبه فالكوست will multiply. In general, let's talk about specific tests. Hemoglobin, you do it for someone who has a history of anemia, underlying diseases that can cause anemia like kidney disease or liver cirrhosis, or if the patient is going to a major surgery with a high risk of bleeding. Platelets, if there is a history of thrombocytopenia, if the patient is going for like spinal anesthesia or epidural anesthesia, you want to go above 50 or sometimes 100. Liver function, if the patient has a history of liver cirrhosis. Coagulation, for example, it's commonly done, but the guidelines is not recommended for everyone except patients who are anticoagulation or they have a history of bleeding dialysis. Otherwise, it should not be done. The chance that a patient will have acquired coagulopathy if they don't have a disease is very, very rare. So if you want to calculate the cost effectiveness of a test, this test should not be done for everyone. Same thing for kidney function. It's only done for people who has a chronic kidney disease, going for major surgery. Urine analysis, for example, you do it only for patients who are going for either you think that they have UTI or if they're going to a urology procedure, because if they have asymptomatic bacteriuria, this is one of the indications to treat. All women should do all women in the reproductive age should get pregnancy tests. All these tests, if you do it, it will not alter the post-procedure complications. It will just give you an idea that what's the baseline of the patient. So in case anything happened after the procedure, you will be able to handle it and you're able to know exactly where's the patient live at. Imaging, same thing. A lot of patients, they get an X-ray for an unnecessary reason. American College of Physicians recommend X-ray only for patients who 50 years old or 50 years old or older, or they're doing abdominal aortic aneurysm or abdominal thoracic surgery. The American Heart Association, they added obese patients with a BMI more than 40. Otherwise, asymptomatic patients with no history of lung disease, they're not going for like low risk, moderate risk surgery, they should not get an X-ray. Now, when it comes to cardiovascular risk, it is one of the most common complications after surgery, and one of the most that people of delaying surgery should be assessed with the surgical team. We like to optimize the patient, but at the same time, we don't want to delay the surgery and adversely affect the patient. These are the risk factors for cardiovascular, major cardiovascular event after the surgery, having a history of cardiac disease, diabetes, chronic kidney disease, age by itself is either by itself is a risk factor, or because a lot of people who are older, they have a lot of comorbidities. The anesthesia class, the ACS class, ASA class, atrial fibrillation, obesity by itself is a risk factor as well, and the functional status, and that's why we ask for it in the history. So the question right now, how do you assess for risk for cardiovascular risk? There's a lot of risk models. The most commonly one are these four, and the first one is the most known one, or the most commonly used one, the Revised Cardiac Risk Index. The American College of Surgeons, they have their own also risk calculator. The myocardial cardiac risk, or MICA, National Society Quality Improvement Project database. This is also known as Gupta risk model. They also have a risk model, and recently, and بصراحة كان يعني it's not very common actually. يعني أنا ما عندي كان خبرة فيه كتير. اللي هو American University of Beirut عندهم recently بالسنة الماضية ب 2019 they published their own risk model بجورنال American College of Cardiology, JAC, and it's actually it's a risk. It's a very good risk model, and now it's being validated as to be probably the best out of all these four. So this is the Revised Cardiac Risk Index, which is the most commonly used one. I'm not going to go over the points. Probably you guys know about it, but just 2 points. Just two important things here. There's like a revised one that removed the diabetes from the score just to make it more focused, and which has had like similar, validity compared to this one. The second thing, this risk index, they found that is not very predictive for vascular surgery. They found that the other one, the MICA or the NSQIP, is more predictive. Now, when it comes to the American University of Beirut score, it is very simplified one. I liked it, and the study actually is very well designed study, and they did really good job. وهذا يعني بخلينا يعني بخلي الواحد صراحة يحكي إنه مش الشغلة مش بالواحد وين كان بأمريكا أو أوروبا، إذا كان عنده الفكرة المناسبة والتطبيق المناسب ممكن يطلع بشيء كويس. عندهم 6 or 7 points: history of heart disease, heart symptoms, age, anemia, vascular surgery, and emergency surgery. With a score 0 to 4, based on that, you will decide. They validated their score. If you can see here, the receiver operative curve, their score is the blue one here, and actually it's outperformed all the NSQIP score and the revised cardiac index score. So I believe this scoring system is going to be more commonly used in the next few years. Now, when it comes to comparing the other, which one to use, this study did not compare the American University of Beirut score, but they compared the four different scores, and they did not find like any significant difference between them. فالواحد هلا ممكن يسأل حاله which one to use. The RCI score is the most commonly one, so I would just go for it for now. هلا you evaluated the patient, you took history, you did blood workup if needed. Now you risk stratified your patient based on one of these risk stratifying scores. Now what to do? Probably this is a busy algorithm. Hopefully you can see it clearly. In case of emergency, you don't have an option. Either your patient to go to the surgery or not. And if the patient also is having acute coronary syndrome right now, it's also probably you don't really have many options to do. Now, if the patient doesn't have any of these two, and he's like very low risk, then they proceed with the surgery without any further testing. If they have elevated risk more than 1% based on any of these scores, you decide based on the functional capacity of the patient. That's why I put the functional capacity questionnaire earlier. If they have a good score, either more than 4 or you don't have to do anything. Now, if they have less than 4 or you're not sure exactly about their functional status, then this is the only indication to do further testing, which is a stress test. And based on the stress test, you decide whether or not to do angiogram or left-sided heart cath. So briefly about the cardiovascular workup, EKG is done not for everyone. We do it for a patient who had a history of cardiac disease, arrhythmias, peripheral vascular disease. If they're going to moderate to high risk surgery, you may consider it for other asymptomatic patients, but if the patient is going for low risk surgery, it should not be done. Echocardiogram is the same thing, should not be routinely done. We do really like for these main indications. Dyspnea for unknown origin, just like as a workup, heart failure with a worsening symptoms, or suspected moderate to severe valvular disease without an echocardiogram in the last year. The stress test, as we said from the algorithm, is not indicated for everyone. It is indicated if they have high risk and they have poor functional status, or the functional status you can't determine, and at the same time, it will change the management. You may consider it for the high-risk patients with a cardiovascular procedure, but most likely these patients will already have cardiac workup done before the surgery. Based on the stress test results, you decide whether or not to do cardiac cath, and when you reach this level, most likely the patient should be seen by a cardiologist. So most likely you don't have to deal with this decision. But cath should not be done for everyone. It should be done based on if they have a high risk features on a non-invasive testing, and even that, like revascularization versus non-revascularization, actually there was a big trial for that. They did not really, the benefit was marginal. So this decision has to be taken by a cardiologist and the surgeon, and the timing for this should be also individualized on risk versus benefit of delaying surgery versus proceeding with angiogram, because you have to delay the surgery 14 days after angioplasty, 30 days after bare metal stent, and 180 days after drug-eluting stent. And sometimes actually report for the American Heart Association report for cardiac risk factors for non-cardiac surgery بال 2014, their guidelines, it says that Sometimes you delay that for 1 year after drug-eluting stent if the surgery is not, it's elective surgery and you can wait for it. Other conditions that you have to optimize اللي هي moderate severe valvular disease. As I said earlier, you do an echocardiogram if nothing has been done in the last year, and valve intervention for severe and asymptomatic patients if they are going into elective non-cardiac surgery. Atrial fibrillation, same thing. You optimize the rate control. After surgery, you optimize pain and fluid balance. If the patient is having ICD or defibrillator, they have to be closely monitored before and after surgery if the defibrillator is being deactivated. And most of the time, these patients should have a cardiology on board. Now, when it comes to medications, beta blocker. So previously, beta blockers, they used to give it for everyone before surgery, and they found that this is not helpful. So now the recommendation is that you continue if the patient is chronically on beta blocker, and you initiate if the patient is a high risk. For example, if the patient he has a history of coronary artery disease or CHF, and he's not on beta blocker, you actually initiate, and they found some benefit from this. However, you don't start the day of the surgery because sometimes they can't tolerate, and they may become hypertensive either before or after the surgery. So you wait 2 to 7 days before doing this. ACE inhibitors, a lot of reports saying it should be held 24 hours before surgery because it may induce hypertension after the surgery. This has to be individualized. However, if you decide to stop it, you resume it as soon as possible after the surgery. Antiplatelets, I'm going to talk a little bit more about it in the next slide, but in general, we hold for 7 to 5 days unless the patient has a PCI in the past, or coronary angiogram with stenting. Statin, you continue if the patient is on it, and you initiate for high-risk patients if they are not already on statins. For example, patient with peripheral vascular disease who's not on statin, you initiate statin, either rovastatin or atorvastatin, and they found actually mortality benefit. Clonidine doesn't help to be started before the surgery, but it should be continued because it might induce rebound hypertension if it was discontinued abruptly. Nitrate, better to withhold because it may induce hypertension after the surgery. Diuretics, you decide based on the patient volume status. If you decide to discontinue, it should be continued as soon as possible after the surgery, especially that most of the time, surgeon and anesthesia are very liberal with fluid, and they may overload the patient very easily. Now, when it comes to antiplatelets, this is algorithm also from the American Heart Association guidelines in 2014. It's preferably not to do any surgery after stenting for up to 4 to 6 weeks. After that, it depends on whether or not this is drug-eluting versus a bare metal stent. In general, you try to delay the surgery as much as possible, at least for 30 days for bare metal stent, a year, or at least 6 months for drug-eluting stent. Let's say that a patient is had a stent 6 weeks ago and he's doing elective surgery. You continue with the dual antiplatelets actually, unless the bleeding risk is high, like for example, neurosurgical patients. If you decide to stop one of them, you stop Plavix and you continue with the aspirin. And you start Plavix as soon as possible after the surgery. If the patient had a stent more than 4 to 6 weeks, then you decide exactly when the timing of that. But again, the whole point is you try to wait for the drug eluting stent at least for 180 days, 30 days for the bare metal stent. If you decide to continue, you continue with aspirin and restart Plavix after the surgery. So that's for it. Let's go back to the questions. Okay. So question number 1, this is the guy who's going for a surgery. What kind of test you would do? Correct. C is the right answer because of his chronic kidney disease. Again, from the lecture, as we said in the lecture, we don't do prothrombin time for everyone unless they have a risk for that. Question number 2, this is the one who has going for urgent surgical procedure, but he has a history of non-ST elevation. His blood pressure is high. What medications you use versus you hold? Correct. You continue all of them. Again, we don't stop aspirin because he had a history of stenting 2 years ago. Unless you think the bleeding risk is really high, then this is the case you stop it. Question number 3. He's going for laminectomy and for spinal stenosis, history of ST elevation without intervention. He's on multiple medications, electrocardiogram. Which of the following is indicated for his surgery? طيب الجواب هو B, ECG. You just do an EKG. You don't have to do stress test for him. And 4, this is the woman who's going for knee arthroplasty. She has history of at least moderate aortic stenosis. By the way, probably I did a mistake on this. أنا بقى هاي it's my sorry. لازم يكون في echocardiogram, مش stress test echocardiogram, no, an echocardiogram, because nothing has been done in the last 1 year, just to assess her functionality. Okay. طيب هذا عنده أي questions على المحاضرة؟
شكرا.
طيب بس بياخذ من وقتكم كم دقيقة بس ندردش على التلي كونفرنس. أولا أول شيء طبعا أنا شاكر لكم لجهودكم دائما تكونوا موجودين يعني وإن شاء الله إنه نضل يعني نحاول بباما نضل يعني نضل على تواصل ونضل نفيد ونستفيد منكم. بس حاب أسمع منكم شو رأيكم بالتلي كونفرنس سو فار. أتوقع هاي بجوز السنة الثالثة اللي عم نعمل زي هيك أو يعني 2.5 تقريبا. شو رايكم ايش في شغلات ممكن نحسنها عادي يعني خليها يعني هاي مناقشه يعني اخويه زي ما نحكي. وهاي مسؤوليتي انا يعني باني مسؤول عن الكونفرنس انه شغلات احسنها. عادي شباب خذوا راحتكم يعني ما
دكتور في مواضيع في الاس دي مش كتير يعني عليها زي الجيرياتريكس والسايكاتريك ديزيز يعني بشكل عام يعني شيء ريليتد للمرض.
اوكي. يا احنا حاليا اللي عم نحاول نعمله انه بنحاول invite people based on او نعمل مواضيع based على اللي هو البرفورمانس بالان سيرفيس اكزام. ما شاء الله انتم يعني السكورز ما شاء الله very good يعني. بس بالجيرياتريك there's like a يعني في ديفكت واضح يعني. يعني انا بتخيل انه احنا يعني انا يعني صح تعلمت بالاردن بس انا اتوقع نفس الليفل. ما عندنا تركيز على الجيرياتريك ولا حتى على الجيرياتريك ساينس يعني. ما بتوقعش حتى في جيرياتريشنز بالاردن او فلسطين للاسف. انا حكيت مع الدكتور مجدي حمارشي هو عنده كان فيلوشيب بالجيرياتريك وفي كمان فيلو. هلا هو يعني he's finishing his fellowship. وان شاء الله he's gonna join the program soon in the summer يعني. فان شاء الله انه we'll try to concentrate on the geriatric topics. Psychiatry the same thing. في الدكتور عثمان محمود أعطى محاضرات بجوز قبل سنتين. I invited him أنه يعطي كمان محاضرات. إذا في specific topics you want to talk about بس خبروني على الجروب وإن شاء الله يعني I will forward to him. أي ملاحظات تانية؟ طب خليني أسألكم هلا. بعرف حكينا قبل هيك بجوز يعني على الجروب انه بالنسبه للتوقيت قد ايه الشانس انه نغيره ونخليه مثلا على مثلا بالبيدياتريك كان هو زي هيك هلا على الساعه 2 عندكم غيرناه وعدناه على الساعه 5. فالمقيمين بعد ما يروحوا they join the lecture remotely يعني من البيت مش من المستشفى. وفادنا انه كمان هلا في other residents من رام الله هلا they joined. قد ايه الموضوع ممكن يزبط مع الميديسن؟ هلا انا احكيكم ليش انا هيك. لانه هلا مثلا الساعه عندي هلا انا لما بلشنا المحاضره كانت الساعه 7. انا توقيتي على توقيت نيويورك على اللي هو على الساحل الشرقي على الايست كوست. في عندنا محاضرين بتعرفوا انه امريكا كبيره. في محاضرين بكون عندهم بالسنترال تايم بالنص بكون عندهم الساعه 6 الصبح. في محاضرين دكتور يوسف خلفي مثلا هو عم عايش بكاليفورنيا على اخر شيء يعني على الويست كوست. لما يعطي المحاضره بتكون عنده الوقت بكون عنده الساعه 4 الصبح. فالمشكله انه لما يعني ابعت انفيتيشن مثلا لواحد يعطي محاضره ويعرف التوقيت بيعملوها على الساعه 6 او الساعه 7 الصبح. فهذا يعني شوي يعني بقيد انه يعني استمراريه المحاضرات. فهلا احنا بنحاول يعني اذا الموضوع ممكن ينعمل هذا شيء كويس. اذا لا يعني خلاص بنخليه زي ما هي.
في وقت محدد انتم بناسبكم يعني الساعه 5 وقت بناسبكم مثلا؟
والله شوف انا يعني بالنسبه الاولويه لكم مش النا. عرفت كيف؟ احنا بنحاول من نأقلم حالنا على برنامجكم.
يعني اذا في وقت معين على اساس مثلا بدك ترفع على الشباب، اذا في اوقات معينه مثلا بين 5 و8 بدك ترفع على الشباب، بنشوف ايش ممكن يكون انسب وقت نتفق فيه مع بعض.
وهلا الشغله الثانيه انه كمان انا حابب كمان الميديكال ستودنت كمان تو جوين. انا اللي بفهمه اللي فهمته انه بيكون عندهم محاضرات بنفس الوقت صح؟
صحيح حكيم، هم جروبين عشان كوفيد، في جروب للساعه 11 وفي جروب بعد الساعه 11. فمشكله بكون كل ما ضل وقت بكون محاضرات
اها طيب. انت شوف احكي مع الريزنت بس كم يعني بالريزنسي بروجرام كله كم واحد كل سنه 4 سنوات انتم صح؟
احنا 14 سنه.
14 اوكي طيب. يعني احنا بنحاول عشان يعني تعمل فائده وكمان نحاول انه كمان ريزنسي بروجرام من اماكن ثانيه. كان في الاهلي ومجمع فلسطين الطبي كمان كانوا بس يعني عشان الكوفيد كمان اخف الانتظام تاعهم. وبنحاول انه يعني الفائده تعم الجميع. شوفوا تناقشوا بينكم انتم، شوفوا شو احسن وقت ممكن، واذا زبطت يعني تكون كويس يعني.
خلاص ان شاء الله حكيم، نضل نتواصل
ماشي،
معك.
مشكورين، يعطيكم العافيه.